So welcome everybody to the second installment of our best practices for clinical care in the World Trade Center Health Program. The title of today's talk is Tracking Diseases Related to the Terrorist Attacks of September 11th, 2001. My name is Jeff Calvert. I'm a physician with the World Trade Center Health Program. My title is the Associate Director for Clinical Quality. I've been with the World Trade Center Health Program for almost 7 years. And I want to thank you for taking time out of your busy schedule to spend this next hour with us. So some disclaimers: the views expressed in this presentation are those of myself only and don't necessarily represent the views of NIOSH or CDC. Any mention of trade names, commercial practices, or organizations do not imply endorsement by NIOSH or CDC. And then finally, citations to websites external to NIOSH, CDC do not constitute our endorsement of that organization, and we are not responsible for the content of those websites. We also have one disclosure. One of our planning committee members attended some promotional programs by a few pharmaceutical companies and also received a lecture honorarium, and those relationships have been mitigated. This presentation, like all of the presentations in our webinar, is based on a paper that was published in the Archives of Environmental and Occupational Health. So this paper was published in 2003. So this, as I mentioned, is the second installment of the series. It's another background lecture. And then after this lecture, we'll be delivering condition-specific lectures. So the next lecture is going to be 2 weeks from today on December 14th. It'll be on obstructive sleep apnea. It'll be delivered by a couple of our colleagues from Rutgers University, Dr. Iris Udison and Dr. Jag Sundaram. So hopefully you can join us for that webinar. That'll be at noon on December 14th. And we should be sending out the invitations for that hopefully soon. I want to acknowledge the participants in our work group that were responsible for putting this series of articles together, as well as this webinar series. And so I've got them listed here in alphabetical order. You can see they're from NIOSH, as well as many of our clinical centers of excellence, as well as the registry. So big thanks to those folks. Also, I wanted to acknowledge the reviewers of an earlier version of the paper that I just mentioned. That's Drs. Harrison and Mulai from the California Department of Public Health and the Florida Department of Health. And then finally, I want to thank the folks who helped me put this webinar together. Kiana Harper, who's with our NIOSH Office of the Director, and Ann Riddle, who's with our the World Trade Center Health Program. So thank you very much to both of them for helping to make this webinar possible. This is an overview of today's presentation. So first I'll talk about or provide an overview of public health surveillance. Then I'll talk about mandatory disease reporting to public health officials and discuss how that's not a very effective way to track 9/11 related illnesses. Given that's not a very effective way, I'll discuss other approaches to track 9/11 related illnesses, including cancer registry linkages, mortality tracking, SPARCS linkages, which are hospital discharge linkages. Then I'll talk about medical interviews and medical surveys of 9/11 cohorts, and then finally talk about US Renal data system linkages. And then at the end, we'll talk about the attributes of the 9/11 health surveillance system. So the attributes that CDC considers when evaluating public health surveillance systems and public health information systems. So overview. So these are two classic definitions for public health surveillance. The first is from 1988. It's the systematic ongoing collection, analysis, interpretation, and dissemination of data to prevent and control disease. So two key words in this definition are systematic and ongoing. So to be surveillance, public health surveillance, it's got to be systematic, meaning you've got you've got a case definition and you've got methods to collect these data, to collect them, analyze, interpret the data. So organized ways of doing this surveillance. And then it's got to be ongoing. So if it's just a data collection one point in time, that's considered research, it's not considered public health surveillance. And then to be public health surveillance, it's got to be for the purposes to prevent and control disease. So a lot of industry does surveillance. They do surveillance like people in the finance industry or people in the retail industry. They're doing surveillance all the time on us to see what we're interested in buying, what products we have bought. So they're looking for new markets and trying to promote their markets, but that's not public health. That's not for the purposes of preventing and controlling disease. That's more for the purposes of generating profits. But industry though, they have very high tech, very classy systems to do their surveillance. We're probably not as advanced in government and with public health doing surveillance, but given the resources, we do the best we can. And the other definition is data for action. So I like that definition, data for action. So that's the whole point of collecting surveillance data, is the data should be used to take action, whether it be to do additional research, to adopt some preventive activities, so some type of action. So if you're collecting and interpreting this data and then not doing anything with it, an argument could be made that what's the point? Those activities should cease. So you really need to be using your data collection for data for action. So these are the uses of public health surveillance, and the items that I have in bold are the ones that are relevant to the World Trade Center Health Program and 9/11. So one is to estimate the magnitude of the problem, also to determine the distribution of illness and injury, either across geographic area, races, ethnicity, sex, gender. You can also use it to monitor disease incidence trends over time, very important. Monitoring changes in exposures and hazards, that could be useful, probably not in our program, given that for all intents and purposes, the exposures ended on July 31st, 2002. Maybe if we develop some type of a biomarker for 9/11 exposures, this could be useful, but until that point, that's not an use for our activities. Same with detecting epidemics. That's more for communicable diseases, infectious diseases, which is not relevant to our purposes. But the next one, portraying the natural history of a disease. So that's very important for us to look at what is the history, what happens to people who develop a 9/11 related disease. So what's the morbidity? Is it worse or better than the US population in terms of who have that same disease? It's also useful for generating hypotheses and to stimulate research, and that happens quite a bit in our program. Evaluating control measures, again, since the exposures no longer exist, that's probably less important for our purposes. And then finally, these data are useful to facilitate planning, which is happening all the time in our program. So one way to collect public health data is through mandatory reporting of occupational diseases. And so this is an important way to protect against occupational and environmental hazards. And this is also called sentinel health surveillance. So what happens here is if you have a reportable disease and a clinician diagnoses a patient with a reportable disease, the physician should report that to public health authorities, basically the state health department. And then when the state health department receives that report, the state health department then ideally should do an investigation, determine the cause of that occupational environmental hazard, because these are all things that should be preventable. So if a person is developing this disease, we need to figure out why, so that once we answer that question, why, mitigation efforts can be adopted to prevent future instances of that disease. So in 1988, there were 32 states that had reporting requirements for occupational disease. That's like 35 years ago, but that's the most recent data that I could find on reporting requirements. So don't think that's probably changed a whole lot since 1988. And then there's likely fewer state reporting requirements for environmental disease, although I think most, if not all, states do require childhood lead poisoning. But apart from childhood lead poisoning, there's not a lot of requirements for reporting environmental diseases. We'll also talk about reporting of cancer to public health authorities. That's done in all 50 states. And then all 50 states also collect vital status data and share it with CDC. So we'll also talk about that in this webinar. So since most of the patients affected by 9/11 still reside in New York, I thought I would report the New York State reporting requirements for occupational diseases. So these are the lung diseases that are required to be reported within 10 days of diagnosis. And you'll see in this table, nowhere does it mention 9/11 related, but there are some diseases listed here that are covered conditions in our program, so that people were exposed to 9/11 did develop. And they include things like industrial bronchitis, occupational asthma, pulmonary fibrosis. So there's many things in here, but again, it's not 9/11 specific. So it won't be a good way to use that system to identify 9/11 related diseases. You could use it, I suppose. It just wouldn't be very effective. Also, heavy metals in blood and urine is reportable to the state health department. So I've got listed here the levels of arsenic, cadmium, mercury, and lead that are reportable. And the nice thing, though, about heavy metals in lead, blood, and urine is that the reporting of that data is pretty much automated from the laboratory. So there's nobody that has to think, oh, do I need to report this? Those data go just directly from the laboratory, like Quest Labs, straight to the health department. Unlike those lung diseases that we have listed higher up in the slide, those a clinician has to take the time to report, fill out the form, submit it to the health department. Although there's interesting, as I was preparing this talk, I learned that there's actually a pilot effort now to try to automate the reporting of these lung diseases. So with electronic health records, you can create a system where the computer can look through the record and look for the codes for these conditions that are reportable. And then if the computer identifies it, it can assemble all the data and generate a report and submit that report to the health department. So as I mentioned, that's currently being piloted. It's being piloted for communicable disease at this time. And health systems have to kind of opt in. So they have to volunteer to participate in that system. But it could be a great way to improve reporting of these conditions, because currently reporting of these occupational diseases that require physician reporting, the compliance with that is pretty low, extremely low. So pesticide poisoning is another condition that's reportable in the state of New York. Radiation illness, likewise, is reportable. And also at the bottom of this slide, I've got New York City. New York City also has reporting requirements that you won't find in the state. Some of them, there's an overlap, like pesticide poisoning, but there's carbon monoxide and ricin poisoning that are required to be reported to the New York City Department of Health. So given that mandatory reporting of these conditions probably isn't an ideal way to track illnesses related to 9/11, we're going to talk about some other approaches that are used in the program to identify diseases that could be related to 9/11 and identify diseases that people exposed to 9/11 are coming down with. So those include cancer registry linkages, mortality tracking, the SPARC system, which is the New York State statewide planning and research cooperative system linkages. That's kind of a mouthful, but again, those are hospital discharge data. Then we'll talk about the medical interviews and exams and medical surveys that are conducted on various 9/11 cohorts. And finally, talk about end-stage renal disease linkages. But before we do that, we're going to talk about the cohorts, the 2 cohorts. And I think this is when we're going to have a poll. So we have a poll here. And the question is, which of the following cohorts continue to enroll new members? And select all of the correct answers. Give you a moment to select your answers and submit your responses. Okay, I think, Kiana, let's go ahead and see what we came up with. So actually, the correct answer is only the FDNY cohort and the general responder cohort are accepting new members. So the health registry does not accept new members. They stopped accepting new members in 2004. So health registry and all of the above are incorrect answers. So let's go on. We'll talk about those in a little more depth here now. So the World Trade Center Health Program. So we provide screening and treatment for persons who were exposed to the 9/11 terrorist attacks in New York City, the Pentagon, and the crash site near Shanksville, Pennsylvania. Basically, this continues the efforts, clinical efforts that were undertaken, that were conceived soon after 9/11 in the New York City disaster area. It provides, as I mentioned, both initial and annual monitoring exams. We provide diagnostic services to detect 9/11 related conditions, treatment for those World Trade Center related conditions. So World Trade Center, 9/11, I use those interchangeably. We also do outreach and education to raise awareness about our program. We also support research looking into diseases that might be caused by 9/11, as well as looking for improved ways to diagnose and treat 9/11 related diseases. And our program has funding through 2090 as part of the 2015 reauthorization from Congress and signed by the president. The World Trade Center Health Registry was established in 2002, created and maintained by the health department in New York City. The purpose is to document and evaluate both long-term physical and mental health effects of the 9/11 terrorist attacks. It includes only people who were exposed in New York, so it doesn't include Pentagon responders or Shanksville responders. It includes FDNY, it includes World Trade Center general responders, and survivors. Survivors being, those are the people who either lived, worked, went to school in the lower Manhattan, or in the within a 1.5 mile radius of the World Trade Center in Brooklyn, as well as people who were passersby and in transit on 9/11. So they did baseline interviews between September 2003 and November 2004. And the cohort was closed after those baseline surveys. So basically that cohort was closed as of November 2004, and they do not enroll any more people into the registry. So they did the baseline survey, and they also do periodic additional survey waves where they go out and basically interview all of their members. They've done 4 to date. The most recent one, I think, was in 2020. So they continue to do those. They have funding to continue. So they'll be continue to do those survey waves far into the future, hopefully. So this slide kind of shows how the 2 programs differ. So this on the column on the left shows the various cohorts. And so I've got listed here the FDNY responders. I've got the general responders in New York who are the responders who weren't affiliated with FDNY. We've got the World Trade Center survivors, and then the responders to the Pentagon and the Shanksville, PA attack sites. And so the next column is the total number of people who are in each of those cohorts, as estimated by the Health Department of New York and reported in the Farfel paper that I've got footnoted as number A, or letter A. And so one thing to keep in mind with those World Trade Center survivors is that basically comprises two groups. So think of like one group are the people who were passersby or people in transit. Basically, in my mind, I think of them as the tourists who were visiting lower Manhattan on 9/11. And we're talking just that one day, 9/11. And out of that 362,000, it's estimated that 300,000 of them, 300,000 are those bystanders, the people in transit, and the other 62,000 are the people who were living, going to school, working in that area. So then if you look at the next column, the people enrolled in the World Trade Center Health Program, you can see that almost all of the FDNY responders are enrolled in our program. You can see that about 75%, I want to say, are enrolled of general responders are enrolled. But for survivors, only 41,000 are enrolled. But again, think back, I just mentioned that 62,000 of those survivors in the total, out of the 362,000, 62,000, that 62,000 are the students, the teachers, the workers, and the people who lived in the area. So I would compare the 40,000 with that 62,000. And the other thing to keep in mind too is to be enrolled as a survivor in our program. It's encouraged that the survivor be sick, because the survivor doesn't get benefits unless they are determined to have a 9/11 related or certified to have a 9/11 related condition. So we tell, and they only get one initial exam. So if they only get that one initial exam, they should wait until they think they have a 9/11 related condition before they do that. So there's probably many other survivors who would be interested in enrolling in our program, but currently are healthy. So that's another reason why that number might be relatively low, but that number keeps growing quite a bit every year. And then we have 1,200 Pentagon and Shanksville responders enrolled in the program. And we don't know what the total cohort size is in that first column of numbers, but we've got 1,267 enrolled in our program. And then the last column are the number of people enrolled in the World Trade Center Health Registry. And you can see that they have fewer FDNY responders. But one interesting thing about that is that all of the health registry, almost all, maybe there's a few that aren't also enrolled in the World Trade Center Health Program, but like 99% of the registry FDNY members are also enrolled in the World Trade Center Health Program. In the registry, there's about 27,000 general responders, and about 7,000 of them are also enrolled in our World Trade Center Health Program. For the registry survivors, they have more survivors in their program than we have, and the overlap there is about 4,000, so not a whole lot of overlap. And there's probably reasons for that. Some of the reasons being that the areas that allow eligibility differed between the registry and the health program. And probably I don't have a whole lot of time to talk about that, but if you go to the paper, you could learn about how the boundaries of the eligibility areas differ between the two programs. So what is the current magnitude of disease among the 9/11 exposed population? So one way to identify or determine that is to determine how many people are certified for a medical condition. And so that's a requirement under the law that created our program. It's a DROGA Act. So in order for us to treat a health condition, it's got to be certified. It's got to be on our covered conditions list as being determined to be related to 9/11 exposures. And the other thing to keep in mind too is our program is not a presumption program. So just because you got the covered condition and you were exposed, that doesn't automatically indicate that that person should be certified. So in addition to having the exposures, you need a physician to attest that those 9/11 exposures were substantially likely to be a significant factor and aggravating, contributing to, or causing an illness or health condition. So the question is, okay, well, what's a significant factor? So a significant factor is a factor that has to be an important factor, that contributed to the development of that illness or the aggravation of that illness. So it had to have made a material contribution. Now, it doesn't have to be the most important, doesn't have to be the only factor or the most important factor, but it has to have it play an important role, have a material effect. The key is it should not be inconsequential or trivial factor in the illness. So, but once a member is certified for a health condition, we cover their treatment, and if we deny certification to a member, that member does have a right to appeal our decision. So as of September 30th of this year, 62% of all enrollees in the program had at least one certification. So a lot of people in the program are certified, but not all. These are a list of the covered conditions. It's not a fully comprehensive list. So if you want the comprehensive list, please go to this website that's shown at the bottom of the screen. But we cover most aerodigestive conditions, and I've got those listed here. We cover many mental health conditions, including PTSD, major depression, substance use disorders, anxiety. We also cover acute traumatic injuries, as well as chronic musculoskeletal disorders, but only among responders do we cover the musculoskeletal disorders. And most of these conditions were added by the law, by the Zadroga Act, but some of them were added through rulemaking. And the ones that were added through rulemaking, I've got listed here: cancers, acute traumatic injuries, new onset COPD, and uterine cancer most recently in 2023. And I've got the dates listed for when those conditions were added as covered conditions. So this is a list of the top 10 most certified conditions in the program. So number 1 is chronic rhinosinusitis, and cancers is number 2, which cancers only gained that number 2 position as of July of this year. So cancers before July, it was number 3. And it's the numbers of people certified for cancer continue to grow. So I would predict that within a year, cancers will be the number 1 certified condition in the program. Just my prediction, but just the way those numbers keep going up every month, it's just a matter of time before cancers is the number 1 certified condition. So I'll leave the slide up to allow you to look at the other conditions in the top 10. And now we'll move on. So, okay, now given that sentinel reporting of reportable diseases to public health departments is probably not a good way to track diseases in our populations. One way to track them is to look at cancer registry data. So we're going to now talk about cancer incidence tracking. So as I mentioned earlier, statewide cancer registries are operated in all 50 states. They capture essentially all cancers in their state, the exception being non-melanoma skin cancer. Those are not tracked, principally because most of the data that goes to cancer registries is collected at hospitals. So if the cancer is not treated in a hospital, in an inpatient hospital, among inpatients, it's less likely to get captured by the cancer registry. And pretty much all non-melanoma skin cancers are not treated as inpatients in a hospital, so it would be hard to track those cancers. The vast majority of the reports to the cancer registry are submitted by cancer registrars, who either could be employed by the state or employed by the hospital. They review medical records, pathology reports, identify individuals with cancer, fill out the appropriate forms, and then submit those forms to the state cancer registry. So it's records-based. The registrars are forbidden from speaking with the patient or the patient's family. which for us was an issue. Like we like to also at NIOSH use these data for identifying occupational cancers. And to identify occupational cancer, you need the industry and occupation of that patient. And often you don't see that information, that industry and occupation listed in the medical record. Physicians generally often don't capture that type of information. So if you want that information, it'd be nice if you could go to the patient and ask them, but can't do that with this system. So there have been many cancer linkages studies done in 9/11 cohorts. One issue with doing these linkages is you need to do the linkage at each individual state. There's not a national system to do these linkages, so it's very time consuming to do these types of linkages. You at each state, you have to submit an application. You have to get institutional review board approval. So it's time consuming. It can be expensive, but a system is currently being developed to try to improve things. It's called the Virtual Pooled Registry Cancer Linkage System, which will assemble data from several cancer registries, several statewide cancer registries into one system, so that when you submit an application, you just have to submit that one application and you submit it, and it goes, you'll be able to capture data from multiple states. This system is being developed by the North American Association of Central Cancer Registries, and actually it's being piloted now, and both the registry and the General Responder Data Center and maybe FDNY are working with as part of this pilot to look at the feasibility of doing these types of cancer linkages. And so studies have been published of cancer linkage findings involving the FDNY responders, the general responder cohort members, registry, both registry responders and survivors, as well as a combined responder cohort, which is very exciting. I find that it's very exciting that a combined responder cohort has been created that consists of the responders from FDNY, general responder, and the World Trade Center Health Registry. And this slide actually provides findings from that combined cohort. So it was a study published in 2022, includes data from 13 cancer registries. And again, they went to each of those 13 states individually, obtained this data. So it was a lot of work to do this study. They looked at cancers that were diagnosed up through 2015. And so on this slide, I've got, this is a figure from that paper. And they report on data for all cancers. There's data for 4 specific cancers and all cancers combined. And then the risks for people who arrived on various dates, when they first arrived, the date they first arrived, as well as working on the pile or did not work on the pile. And the way to interpret this figure is, if you look on the right, you see all these lines, these horizontal lines, and you see a vertical line in the middle. So that vertical line at the 1.0, that indicates if you've got either a dot or a vertical line range that overlaps with that 1.0, that means that whatever risk, these are standardized incidence ratios. So if that horizontal line crosses the vertical line, that means that that risk estimate is not statistically significant. So what you want to look for are lines that are completely to the right of that vertical line, and those are the ones that are statistically significant. And so I've got many of those circled on this slide, and you could see that the risks appear to be highest among people who first arrived on September 11th, both for all cancers, for tonsil, melanoma, skin, prostate, and thyroid. Again, so if the horizontal line doesn't cross that vertical line, that means that estimate, that standardized incidence ratio, is statistically significantly elevated, suggesting that it's less likely that bias is responsible for that finding. Although you know, there's a lot of things that could also explain it. Doesn't necessarily mean that there is a causal relationship, but it means that there's it's less likely due to chance if you have a statistically significant elevated SIR. So now we're going to talk about mortality tracking, and I think we have time for another poll. This will be our last poll. So which of the following are characteristics of the National Death Index? And again, select all the correct answers. We'll give you a moment to select and submit your response. Okay, Kiana, let's see what we came up with. So the correct answer is all of the above. So it's considered a complete tally of all US deaths. It's maintained by CDC. It can only be used for research and public health purposes. So all of the above are correct. So it looks like most of the people got that right. Thank you. So before we go into actually the mortality National Death Index, I want to talk a little bit about this Responders Fatality Investigation Program, which you may not be familiar with. It was established in 2006 by the state health department. And the issue at that time was there had at that point not been any mortality studies conducted or published. And so the concern at the health department was, okay, we've got these programs in the city, they're doing morbidity tracking, they're doing these exams of World Trade Center exposed persons, but we have no idea whether or not people are dying in excess because of their 9/11 exposures. Nobody was looking at mortality, or at least nobody had reported it yet. The first mortality paper published wasn't published until 2011, and that was by the registry. So this is a program that was started in 2006 to try to address that gap of what's our 9/11 exposed persons dying more likely to die, and if so, what were they dying of? So the health department was interested in getting any death report that involved a responder. So they started this data collection in 2006, ended it in 2009. And they, one issue was they didn't have a comprehensive list of all the individuals who were involved in the response. And that's still an issue today. We don't still to this date, nobody has a comprehensive list of everybody who was involved. If the health department at that time had that list, they could have easily have done an NDI linkage. But instead, they did outreach to over 200 groups, including clinician groups, entered into data sharing agreements with FDNY, with health programs that monitor the general responders, with the health registry. And ultimately, they identified 814 deaths, 45% of which were identified just through reviews of newspapers or obituary search engines. So daily reviews, just looking, getting online and looking at newspaper obituaries. 28% of the deaths were shared from the health registry. 18% were shared by attorneys, and 9% of just a miscellaneous multitude of other ways. And so the findings from this program were never published in the peer-reviewed literature, but you can find a report online. They did SMRs and proportional cancer mortality ratios. None of the SMRs were significantly elevated. But if you can see that there were elevations in some of the proportional cancer mortality ratios, but those have a lot of limitations and weaknesses. So now let's talk about death certificate data and the NDI. So as I mentioned, all states collect vital status data, meaning death data. They submit it to the CDC, which we maintain the National Death Index, considered a complete tally of all US deaths going back to 1979. We standardize, or NDI standardizes, the underlying cause of death using computer algorithms as well as nosologists. and it can only be used for research, public health purposes. You know, we thought we're as a program, a health program, an administrative program, you know, we provide health care to these members, and it's always nice to know if a member has died. It would be nice to know that fact so that we could cut off the benefits and avoid fraud, waste, and abuse. So we reached out to our colleagues. You know, we're both CDC, NDI. We reached out, hey, can you help us out and give us the death index, your death data to let us know which of our cohort members are deceased for our administrative purposes. And they said, no, we cannot do that. We only share our data for research and for public health purposes. So that's why we had that in that poll. The limitations of death certificate data, it's not perfect. These causes of death are recorded by the physician, and the physician may, you know, often physicians are not given training on how to fill out a death certificate. So what they put on there may be incomplete, may be inaccurate. They might just put cardiac arrest. You're not supposed to do that. So also the person who fills out the death certificate may not be fully aware of what the decedent's health record was. So not having complete medical information makes it difficult to put correct information on the death certificate. And also, this is not a good source of data for non-fatal disease. The mortality studies using NDI have been published for many 9/11 cohorts, including the FDNY responders, general responder cohort members, registry responders and survivors, and again, that combined responder cohort that I'm really excited about. So this is findings from a paper, again, from the combined responder cohort published earlier this year. And so they report adjusted hazard ratios. And so what they did, on the left, I've got in green highlight the date of first arrival for 9/11, 9/12, and then 9/13 and 9/17, and the risks of mortality for those groups compared to what I have in yellow. The comparison group were people who first arrived between September 18th and June 30th of 2002. And what's interesting about this, and then the columns provide data for all-cause mortality, heart disease mortality, cancer-specific mortality, and then smoking-related mortality, which is kind of a hodgepodge. That smoking-related mortality includes many cancers that are smoking-related, cardiovascular disease, diabetes, and many pulmonary diseases. And what kind of strikes me about this table is all of the elevations, which again, the confidence intervals that exclude 1.0, they're all in this non-FDNY, non-GRC group, meaning those are the people who are enrolled in the registry, but are not enrolled in either the GRC or the FDNY. So on an earlier slide, I showed you the overlap between those two cohorts. So for some reason, the people who are not part of our health program cohorts, the World Trade Center health program, seem to have higher mortality. But if you want more detail on that, I would refer you to this paper, the Lee et al. Paper. Next, we'll talk about hospital discharge data. So this is, not every state has this type of a system. New York State is one of the ones that does have it. And fortunately, more than 50%, I think it's slightly more than 50% of persons affected by 9/11 are still living in New York State. So the Sparks system was developed through cooperation between the healthcare industry and the state health department, state government, enabled by laws passed in New York State. For inpatient data, the data go back to 1982. They also have emergency department discharge data going back to 2005. Includes data from all hospitals except federal hospitals, which would be VA hospitals, Veterans Administration hospitals, and military hospitals. And also it does not include psychiatric hospitals. But where data is available, It's a rich data set, includes personal identifiers, it includes the admitting diagnosis, the principal diagnosis, which is the condition, chiefly responsible for the admission, as well as up to 24 secondary diagnoses. So again, like all systems, this one's got limitations. There could be disease code entry errors, so leading to misreporting, which could lead to over or underreporting. These data are limited to persons hospitalized in New York State, so it's not clear, are they representative of all 9/11 exposed persons across the country? We don't know. And again, this data system is ideal only for diseases where you're likely to require inpatient treatment. So things like autoimmune disease, where it's pretty rare that they get hospitalized for their autoimmune condition. This is not a good system. But there have been studies, again, of 9/11 cohorts using this system, and I've got a couple of papers listed on this slide. So given that we talked about mortality, we've talked about cancer, we've talked about hospital discharge. So, you know, those systems require either you to be dead or hospitalized, but is there a more sensitive system for people who don't have such severe disease? How can we track them? So the way we could do that is both through the health program and the health registry, longitudinal health information is collected. So with the health program, members receive an annual comprehensive monitoring exam. So all responders are eligible for that, as well as survivors who are certified for a health condition. So we talked a little bit about survivors who aren't certified. They only get that one initial exam. And if they don't get a certification, they really don't have any other benefits from the program. But the people who are eligible, it's encouraged that they receive their annual comprehensive exam. And then the World Trade Center Health Registry, they also, as I mentioned, do periodic survey waves. They've done 5 to date. There's going to be more planned for the future. So that's how they're tracking. In both of these data collection efforts, they administer questionnaires that ask about a whole bunch of different health conditions. So this is a nice way to identify diseases that might be related to 9/11. So limitations are, in our program, World Trade Center Health Program, only about 65% of eligible persons actually receive their annual monitoring exam. In the registry, about 55% of the registry participants completed the most recent, the survey 4. I haven't seen data for the 2020 survey. So one possibility is that people who are more ill may be less likely to participate in these data collection efforts, unfortunately. Another issue is, again, we don't have a master list of all persons with 9/11 exposures, so it's unclear if the people involved in these programs are representative of the source population. And for the most part, a non-exposed comparison group does not exist, although with the fire department, they've actually created a comparison group that consists of firefighters in 3 other cities, and I think they're recruiting other cities. So they've got currently San Francisco, Chicago, and Philadelphia fire departments. So that's a group of firefighters who have similar exposures to the New York City firefighters, but in these other cities, they weren't exposed to 9/11. So you can kind of tell by comparing those 2 groups, you possibly could identify the effects from 9/11 exposures. And this is an example of data that was used using these data. So this is from the general responder cohort, looking at asthma, self-reported asthma, both a lifetime. They ask, have you ever had asthma? That's the lifetime. Or the question for the 12-month is, have you had asthma within the past 12 months? And you can see that in both the solid lines are the World Trade Center exposed persons. The gray lighter lines is the National Health Interview Survey, which is a nice nationally representative survey of the US population. And you can see both when looking at 12-month as well as lifetime asthma prevalence, the prevalence is higher in World Trade Center exposed persons. So again, this is this is asthma, often is not fatal. So you typically may not find this in mortality data. You may not find it in hospital discharge data, because a lot of times people aren't getting hospitalized. They might go to the ED, so you might be able to track it with the ED data. But here, using just the medical questionnaire data, we're able to share these findings. And so asthma is a covered condition. So now we're going to talk about end-stage renal disease. So end-stage renal disease is when kidney function is no longer capable of maintaining life. So either you get treatment, which is either dialysis or a kidney transplant, or unfortunately you die. Principally, it's caused by diabetes, hypertension, less commonly caused by glomerulonephritis, interstitial nephritis, and there's a whole host of other conditions that can cause it. So the interesting thing about end-stage renal disease is Medicare covers the cost of this treatment for everybody. Anybody can get their end-stage renal disease covered by Medicare. You don't have to be over age 65. Everybody can get this coverage. So not everybody does use Medicare though. You know, if you're rich, you self-pay. Some poor people use Medicaid will cover it. But Medicare covers 90+% of all the end-stage renal disease treatment in the country. So if you have the claims data from Medicare for end-stage renal disease, you have basically a registry of all the people in the country with end-stage renal disease. And so that claims data actually is available to researchers through the US Renal Data System. So it's the only disease that I'm aware of where we have a comprehensive list of all the people in the country with that disease. And so it's been successfully used, looking at the toxicity to the kidney from occupational exposures, and papers have been published related to these various exposures listed on this slide. And it's encouraging that even the cohorts, the 9/11 cohorts are at as I speak, being linked to the US Renal Data System. So to my knowledge, no papers have been published yet on 9/11 cohorts using this data, but that's just a matter of time and those papers will start to come out. So attributes of the 9/11 survey information system. So we talked about usefulness of the system, and then the CDC also likes to look at these other attributes, which we're kind of getting low on time. So I will just, the attributes are, I'll just talk about them really quickly. Simplicity, flexibility, data quality, acceptability, sensitivity, value positive, representativeness, timeliness, and stability. And so you can, I've got definitions of what each of these terms mean here. You could go to this reference at the bottom of the screen to get more information about these attributes. And then this is my opinion of how we do in our program. So we're not a simple system. It's a complex system, but we are flexible. We think we have good data quality. We think the acceptability is good. We think the sensitivity for what we collect. We're collecting much of the diseases that affect our population. We're also, I think the predictive value positive is good, probably very representative, although, you know, there's still not definitive proof of that. We could do more work on timeliness, need to work on that. Stability, we've got good stability. Our program's funded to the year 2090. So in conclusion, the terrorist attacks of 9/11 placed nearly 500,000 people at increased risk of disease. Given the lack of public health reporting requirements for 9/11 related diseases, there are many mechanisms that are used to track the disease in the program, often with excellent success. And we think the program serves as an example for future large-scale environmental disasters. So that is the end of my formal remarks. we have time maybe for one question, Anne, before I talk about the continuing education requirements.
Sure. We had one question and then one comment in the chat. Michelle Hyde had asked if do we mean that they only get one chance to certify for benefits, or do they only get one reimbursed chance to certify? I clarified in the chat that per the Sadroga Act, only the screening eligible survivors are eligible for one initial health exam, but they're more than welcome to, if they have symptoms later on and their doctor believes it's related to their 9/11 condition, that they can submit for certification. Was there anything you wanted to add to that?
I guess the other thing that too, if the survivor wants a second initial health exam, they can get that, but they would have to either pay for it themselves or have their private insurance company pay for it. So we only offer one initial health exam at no charge.
Awesome. Thank you for that clarification. And then another guest had said that FDNY is also piloting VPRCLS. So with that, I think you can go on to the continuing education information.
Okay.
Thank you, Dr. Halbert.
So as I mentioned, continuing education is available for these disciplines: physicians, nurses, pharmacists, public health professionals, physician assistants, and other professionals. So to get your credit, you need to go to this website that I've got listed here. And I would recommend that you take a screenshot of this slide. It's going to help you because when you register, so once you log in, if you haven't set up an account yet, when you set up the account, they'll ask you a couple of security questions, and then every time you log in the future, you're going to be asked those same 2 security questions. So try to make them easy so you don't forget them. And then once you're logged in, you'll basically see these options here. You want to hit the option search courses, and then there's a couple of ways to identify our course. One is to type in the course number, which for this live session, this is the course number. People who we're recording this. So if you're watching the recording, you would use this number here. And so if you don't have that, the other way to do it is you could put your CE type. For me, it's physician, CME, and then when you click on this date, it'll give you the most recent 3 months. So if you click on November, you can scroll through the courses in November. And I think I checked this morning, we're the last listed course. So right now there's 8 pages of courses, maybe about 10 courses on each page. So if you go to the 8th page, you'll see our course. You don't need to remember this number. And then once you enter that information, hit search, you should find us. You'll need to do an evaluation of the webinar. And then once you submit your evaluation, you'll be given a post-test. Consists of 4 questions, and you need to get 3 of them correct to get your credits. And so for the live lecture, credits are available until January 1st of 2024. So for the next 30 days, don't wait too long to claim your credit. And if you wait, or if you're watching the recorded version, those credits are going to be available for 2 years. And so will be available until December 1st of 2025. And so good luck with that. And we're at time. Thank you so much for joining us, and hope you can join us again on December 14th when we talk about obstructive sleep apnea. Have a good rest of your day.